But if you picked up on the fact that around your menstrual cycle every month you're having a migraine,
this TikTok truly bothered me because I don't know how many people were led astray, how many have been evaluated incorrectly for menstrual migraine, how many were treated incorrectly for menstrual migraine, and you'll see why towards the end of this video. He says,
if you're constantly getting migraines around your menstrual cycle, keep in mind your menstrual cycle is your monthly report card.
not for migraine. Completely normal menstrual cycles can cause a menstrual migraine. We will actually learn a little bit later that it's because of a very normal menstrual cycle that females do get migraine flares, but it gets worse.
And if you're having migraines, something is wrong.
No, nothing is wrong other than migraine itself. You are not doing anything wrong that you need to fix unless you have the ability to fix your genetics and physiology. Of course, maintaining a healthy diet and exercise may help symptoms, but it doesn't cure migraine. We do not have a cure for migraine, only treatment. In fact, 60 to 70% of females with migraine also experience menstrual triggers. Considering this is most females with migraine, it is safe to assume that it is a biological and genetic issue.
Hi, I'm Nurse Doza, holistic nurse practitioner from Austin, Texas, and I help people from all over the country.
Hi, Nurse Doza. Let's see if you're helping people.
Let's start off with migraines are never a good thing.
Really? Thanks for this knowledge. Tell us more.
And honestly, if you're having chronic migraines, something is wrong in your body. It's a signal for inflammation.
If you are diagnosed with chronic migraine, then you have chronic migraine. That's it. If there are very elevated inflammatory markers, that may actually rule in a secondary headache like giant cell arteritis. Some studies do show migraine patients may have an elevated ESR and CRP, which are inflammatory markers, but others show no clinical significance. Furthermore, inflammation is not the root cause of migraine, but the physiology of migraine causes a cascade of events that results in neurogenic inflammation.
And you need to figure out what's causing the migraines, because taking medication and pain meds over and over again is not getting to the root cause.
Medications for migraine are essential. It also may prevent chronification that is very difficult to reverse and has anatomical and functional consequences. I have written an article on this and made a video on TikTok as well. Furthermore, you were just talking about inflammation, and we now have CGRP inhibitors that directly block a neuropeptide that contributes to neurogenic inflammation. The root cause of migraine is genetic and biological differences that we can't change, but we can use medications to either help prevent or abort migraine flares.
But if you picked up on the fact that around your menstrual cycle every month you're having a migraine, then I think something's going on with your hormones.
Then you think wrong. No, nothing is wrong with your hormones.
But when it comes to your menstrual cycle and it comes to your hormones, keep in mind there's a lot of hormones involved.
Yes, but which of these hormones impact migraine? I mean, that is what we're talking about here, isn't it?
So it's really hard to predict which one's causing the issue unless you do labs.
No, it's not hard to predict because we already know. The problem here is that you seem to be predicting things because you don't know the science. So let me take this opportunity to go over the menstrual cycle and how estrogen plays a role in menstrual migraine. First, there's only one hormone we know that matters, and that is estrogen. Prostaglandins also matter, but that's not a hormone. And it's not the absolute value of estrogen, but the drop in estrogen that matters. This drop that we see here in estrogen is what matters. So it's irrelevant if estrogen is normal, high, or low. What's important is the change in estrogen. The change in estrogen is what matters. So if you look at a menstrual cycle, and I'm not privy to what they teach in nursing school, but I am assuming some endocrinology is part of the curriculum. We have the hypothalamus, so let's just draw out a brain here. Terrible sketch of the brain. Sorry about that. Let's say the hypothalamus is right here. This is the sagittal view of the brain. So the hypothalamus would be right there, where I drew that green down. So the hypothalamus is part of the brain, and we have the anterior pituitary. Let's just change color here. So we have the anterior pituitary. This is the anterior pituitary. This would be the posterior pituitary. But the posterior pituitary doesn't matter here. It's not creating hormones that we care about for the menstrual cycle. So the hypothalamus creates GnRH. So let's switch back. GnRH. That's gonadotropin releasing hormone because it releases hormones in the gonads. So GnRH causes the release of FSH and LH from the anterior pituitary. So follicle-stimulating hormone and luteinizing hormone in the anterior pituitary. Again, sorry, handwriting sucks, drawing sucks. It's fine, just follow along. So we have ovarian cycle phases. So we have the follicular phase here, and then we have the luteal phase here. Okay, so this is the follicular, let's just do F, and this is the luteal phase. These are the ovarian cycle phases. So in the follicular phase, we have FSH that is being produced by the anterior pituitary, resulting in primary follicles, maturing into secondary follicles. And these follicles have cells that help produce estrogen. So we have FSH and LH acting on an ovary, and this ovary produces estrogen. This is called the hypothalamic pituitary gonadal axis. Basic endocrinology, it can get a little confusing if you've never seen it before, but this is the essential idea. Okay, you have a releasing hormone, and then you have that acting on the anterior pituitary that releases more hormones, then that acts on the gonads, and that releases more hormones. So these follicles have cells that help produce estrogen, which prepares the uterine lining, aka the endometrium, for potential implantation of a fertilized egg. Estrogen also causes the hypothalamus and the anterior pituitary to reduce FSH and luteinizing hormone, the negative feedback loop. So as estrogen is being produced, estrogen also tells the hypothalamus to start decreasing GnRH production, start decreasing FSH and LH production. And it's not just estrogen that has this negative feedback mechanism. Everything on the hypothalamus pituitary axis really has negative feedback mechanism as well. And what's important about this feedback mechanism is so that we don't have multiple follicles growing, but the dominant follicle will allow estrogen to continue to increase. So we see estrogen continuing to increase on this graph, right? You see how estrogen is increasing? It's continuing to increase even though there's a negative feedback loop, but it's continuing to increase because the dominant follicle is allowing estrogen to continue to increase. However, simultaneously, as estrogen is increasing, we also notice a decrease in FSH and LH, and that's the negative feedback mechanism. But then you might be realizing FSH and LH increasing right here. So what's going on here that's causing FSH and LH to increase if we just said there's a negative feedback loop? Estrogen is increasing, and there's a negative feedback loop here. Why is it that LH and FSH all of a sudden increase? When estrogen levels reach a certain threshold, it reverses the negative feedback loop, and it becomes a positive feedback loop. And this causes an increase in LH, known as the LH surge. So this is LH, right? This is LH. This is known as the LH surge. This LH surge causes ovulation, which is the release of the mature egg. LH also stimulates the leftover follicle cells to become the corpus luteum. And so when the corpus luteum, let's say this is the corpus luteum. So when the corpus luteum is created from the leftover follicle after ovulation, this corpus luteum secretes progesterone. So this corpus luteum secretes progesterone and some estrogen as well, not as much. But the main thing is that it secretes progesterone, and that's why you see progesterone now increasing. So we have progesterone as well being produced by the corpus luteum after ovulation. So as progesterone is increasing, there is a negative feedback loop on the hypothalamus and on the anterior pituitary. And so we have a decrease of FSH and LH again, right? It's decreasing here. Sorry, this is kind of messy at this point, but I hope you're following along. Progesterone also primes the endometrium for implantation. So if there's no implantation, this corpus luteum degenerates. So there's no longer progesterone and estrogen. Progesterone rapidly falls, and so does estrogen. And progesterone rapidly falling is what causes the endometrial lining to slough off, and that's menstruation. So once progesterone drops, menstruation occurs. Remember, the migraine flare must occur at 1 plus or minus 2 days of menstruation to be a menstrual migraine. So menstruation is day 1, and there's no day 0. So it's either 2 days before or 2 days after. Unfortunately, day 0 is on the graph. I don't like it when some graphs show day 1. I prefer day 1, but it's day 0 here. So what happens right before, okay, there is a drop of estrogen and progesterone. Right here, this window, let me increase this window is what matters. There's drop in estrogen and progesterone. And there's really no change in LH and FSH, right? Look at this. There's no change in LH and FSH. But there is a change in estrogen and progesterone. And why is there no change? Because like we just talked about, they were being suppressed through negative feedback due to the corpus luteum making progesterone and some estrogen. So because of the negative feedback of the progesterone being created by the corpus luteum and some of the estrogen, LH and FSH have been suppressed. So how do we know the dropping of estrogen and not progesterone before menstruation is what matters for migraine, right? Because as we can see here, this is menstruation, right? So there's a drop of progesterone here, and then menstruation begins. So how do we know it's the estrogen drop and not progesterone before menstruation that causes a menstrual migraine? Well, let's look at the science. In this study, 1 intramuscular injection of estrogen delayed the drop of estrogen. So let me erase some of this. If we inject exogenous estrogen, we would keep levels higher. It wouldn't dip, so it would delay the drop of estrogen. But as we already talked about, menstruation is a result of progesterone decreasing. So menstruation will still happen because progesterone is still decreasing. But we just gave an intramuscular injection of estrogen. So the shedding of the endometrial lining still occurs. So there was no delay of menstruation. So what about a migraine flare? What happened? Those were delayed. So an estrogen intramuscular injection resulted in menstruation occurring without a migraine flare. So that's the first clue. It's estrogen that triggers these menstrual migraine flares and not progesterone. Another experiment was done with intramuscular progesterone injections. They were given daily for 3 to 6 days prior to menstruation. So instead of what we had here, with the estrogen, we have progesterone being level and estrogen still dropping. What happens? There would be no menstruation, right? Because again, the drop of progesterone is what causes menstruation. So the result was no menstruation, but there was still a menstrual migraine because of the drop of estrogen. So migraine still occurred. Migraine flare still occurred. Menstrual migraine still occurred because of the drop of estrogen. So we know it's a drop of estrogen, not progesterone, resulting in menstrual migraine. So let me erase this because it's hideous. So you may notice that there's also another drop of estrogen here. So why is it this drop of estrogen resulting in a menstrual migraine? Because we have 2 drops, right? We have the first one here, the second one here, right around ovulation and right before the menstrual cycle. So why is only the premenstrual drop associated with migraine flare? So it could be the longer exposure to high estrogen levels in the luteal phase. The luteal phase is just the second half of the cycle, of the ovarian cycle. And this could cause genomic effects on estrogen receptors. It could also be other factors uniquely present at the end of the luteal phase, like the release of prostaglandins. It could also be an interaction with falling progesterone levels that also occur premenstrually. So let me erase this. As you can see, when estrogen falls, progesterone is not falling. However, in the second drop of estrogen, progesterone also drops. So it's possible that progesterone is protective, and it's why studies show the headache severity is lowest during the mid-luteal phase, where progesterone is highest. But estrogen withdrawal can still trigger migraine flares through hormone changes alone without requiring ovulation or menses. We see this when women on hormonal birth control have a placebo week or when postmenopausal women stop hormone replacement therapy treatment. This shows the key role estrogen fluctuation plays independent of bleeding.
And that's why I'm a big proponent of lab work, because when you do labs, especially around your cycle or maybe even mid-cycle, you can see which hormones are up and which ones are down. And you can see which ones are out of range and which ones are in range. And then you can get to the root cause and do something about it, which means less migraines in the future.
What will you do with the labs? Even if you focus on estrogen, we don't know the minimum threshold of estrogen concentrations where menstrual migraine flares occur, nor do we know if there is a difference in absolute estrogen between women with and without menstrual migraine. What makes this worse for you is that the drop in estrogen may trigger flares, but migraine flares don't necessarily happen on the day with the lowest estrogen level. So it's not even about the estrogen concentration, as there are unknown factors that seem to influence the exact timing of when flares occur around menstruation. Also, labs are not necessary for a diagnosis of menstrual migraine, and they won't even be interpreted properly because they don't say anything. Are you really saying that 60 to 70% of women with migraine also have issues with their menstrual cycle? Because like I said before, that's the percentage of females with migraine that also have menstrual migraine. So why are you even asking for labs? Patients do not need to go through this unnecessary workup that has zero clinical value. I would love to know what you look for when you see the lab values and how the treatment changes as a result, because this is very suspicious. You're essentially using a cookbook to fix a car. Labs for this don't make any sense, but if you would like to expand on specifics, I'd love to hear it, but something tells me you won't.